Hi, everyone. Welcome to the April TICN presentation. My name is Laura Gadenik, and I'm the TICN program coordinator. If anyone is here for a CEU, if you could email me, I'll put my email in the chat. Email me that you're here for a CEU, and then I will send it to you after the presentation. So my email is ticnutah@gmail.com. Additionally, I will send out Brian's slides at the end and the recording, as well as additional resources he may have. For those of you who don't know, TICN stands for the Trauma Informed Care Network. We've been around since 2014, and our goal is simply to educate folks in the community, not only therapists, but people generally, about trauma-informed care and various trauma-informed care modalities. We also do a monthly newsletter that I'm sure a lot of you receive, and we really want to be kind of a connector to disseminate information about various trauma-informed opportunities and things going on in the community at large. So today we have with us Brian Curtis. Brian Curtis is a clinical psychologist and founder of Honest Sleep, a telehealth-based clinical practice specializing in the assessment and treatment of chronic insomnia and nightmare disorder. Dr. Curtis received a master's in neuroscience and a doctorate in clinical psychology from the University of Utah. He has over 12 years of research experience. He has published 11 peer-reviewed scientific publications in some of the world's top journals in sleep medicine and neuroscience, and is a member of the American Academy of Sleep Medicine and Society of Behavioral Sleep Medicine. Dr. Curtis's work includes targeting comorbid sleep disruption for individuals diagnosed with borderline personality disorder, post-traumatic stress disorder, generalized anxiety disorder, and major depression. As sleep disruption is transdiagnostic across most mental health concerns, Dr. Curtis is particularly interested in helping fellow mental health providers increase their competence in the assessment and treatment of sleep-related difficulties with their clients. So with that, I will hand it over to Dr. Curtis.
All right, thank you so much. I appreciate that. And hi, everybody. It's incredibly exciting to be here today talking to you. And so I see a bunch of names. I hope to have this interactive today and not just me lecturing at you. So I know it's recorded, but if you're, so bold to have your camera on so I can see your smiling faces, you don't have to, but that would be great. So really today I want to talk about how we think about assessing, but also treating sleep disruption. And if you're a clinician who works with clients with trauma-related difficulties, this is the central theme that I want to present on today. And so we will cover a number of topics. One, we're going to start with talking about sleep in general, and then a few notable sleep disorders. Insomnia and nightmare disorder in particular will be focuses, but we'll also talk about some other sleep disorders that may come up and to have on your radar when you're working with people with trauma-related difficulties. We'll then transition to talking about the importance of sleep in PTSD, right, in trauma and post-traumatic stress disorder. And then we'll shift into, well, how do you actually do this? Like, talking about it's one thing, but what are those tools to be able to go right from today to start asking about sleep and feeling confident, right, about asking about sleep? And then critically, knowing what are the gold standard evidence-based treatments for insomnia, for nightmare disorder. And then we can end by having some actual case examples of putting these skills into practice in kind of an interactive way. So that's the outline, but I like being flexible too. And with that in mind, I do like to start with just having kind of an open conversation about what have you noticed about sleep? I mean, if you work with people with trauma-related difficulties, if you're somebody who might have had sleep disruption, if you have a trauma history yourself, and in particular, what were you kind of hoping for most to learn and take away from the presentation today? Just kind of want to open it up and hear your experience with sleep.
I will be brave.
Yes.
I'd like to know, like, I was hoping I'm not sure if this is where this is going to go, but just ways to help clients, any new information that's out there beyond what I may already have about, like, how do we help them get sleep? It's critical to mental health, but some people just have these just like chronic sleep issues. So just seeing
Yes.
what's the latest information and if there's anything helpful we can recommend.
Great, Regina. That is what we will talk about today. So thanks for that. Appreciate that.
Hi, Brian. I want to echo what Regina said. Is I'm really looking for. This is Corey Lynn, by the way. I'm looking for, just some interventions and ideas beyond the normal, sleep hygiene recommendations. Most of my clients have post-traumatic stress disorder or trauma-related type issues, and so therefore like a lot of sleep disturbances and nightmare disorder type issues that are happening. And I feel like I'm kind of maxed out on everything I've used so far and would love to hear some new ideas. So I'm really looking forward to learning from you. Thank you.
Awesome. Thank you. Yeah, that sounds great.
I'll add something. So I've noticed with a lot of my clients, just like this cycle of clients with trauma, a lot of times, like you said, they tend to struggle with sleep, and then not sleeping tends to exacerbate their symptoms of trauma and their ability to manage and regulate their emotions. And then it can feel difficult when they're not sleeping to start working through trauma, because when you're not sleeping, it can make it really difficult to be able to regulate and manage emotions. And so it's kind of like what do you work on first? Can be hard to figure out what's to tackle sometimes.
That's right. Thanks, Morgan. Yeah, the chicken and the egg, right? This is a cycle that tends to feed into each other. Great. Yep.
I'll maybe go next. So I work with, sorry, my kitty is wanting to join the meeting.
Cats are welcome.
I am a birth and postpartum doula, and I sit on the board for Postpartum Support International's Utah chapter here. And I work with a very specific demographic of people that are having really common sleep disruptions, either in late pregnancy or early postpartum, and a lot of whom have experienced trauma in more recent months from their birth experience or in the past. So I'm interested just to hear some new ways to be thinking about sleep and talking about sleep with clients of mine and amongst other perinatal health professionals.
Great. And so thank you all. I'll go ahead and in the interest of time, I mean, some themes emerging, really treatment recommendations. We have sleep hygiene, we've seen the handouts, but what are some of the other evidence-based skills that we can kind of bring to the table? And while recognizing, well, what do we actually do, right? If we treat trauma, we know insomnia and nightmares that's 2 of the 20 criteria we're looking at. Won't those go away when we treat the trauma? Where do we kind of start? Those will be big themes. So thank you all for that. I'm sure we could have, even longer of a discussion, but let's just kind of move into what are we even talking about when we talk about sleep and sleep disorders. So this can sound simple, but just like when we say, what are emotions or what is trauma? I'm just curious, no right or wrong answer, but what kind of comes up for you all? Just anything that comes to mind. What is sleep?
Hi, this is Mary Martineau. Can you hear me?
I can, Mary. Hi.
Okay, good. I don't know why my camera's not working. I'll play with that in a minute. But I'm a trauma therapist, and I think about sleep. It's so complex, and we're just beginning to understand it. But there's, the resting the body, there's the rejuvenation, and then there is REM sleep, where we are, the rapid eye movement, where we are processing, reprocessing, and possibly integrating our learning, what's gone on during the day. And definitely when we have trauma in our life, we're trying to figure that out. The brain's trying to figure that out. And so it can be when people are grieving. I'm a grief therapist and a trauma therapist.
Mm-hmm.
That's the time a lot of grief work gets done. It's when we have time to do it. And it's very disruptive because it's not processed, it's not integrated. So we have the nightmares, and we have the waking and can't get back to sleep. So it can be very disruptive. That's my answer.
Great, thank you. Yeah, and so you're touching on a number of things. You're touching on the function of sleep, the different stages of sleep. I see in the chat, Rebecca has sleep as a form of processing life experiences, possible restoration, and a growth experience. Absolutely, this is gold stars for everyone. And just like, Mary mentioned, this is incredibly complex. And so one way we can think about it, this comes from the newest edition of, a book that if you got hit with it, it can knock you unconscious. It's very, very big. But Principles and Practice of Sleep Medicine, one way we can think about sleep is in terms of behavior, what we can observe. And sleep is it's a reversible state, right? We tend to disengage from our perceptual environment. We're not responding to the environment, but that's reversible. It's not permanent, but this is a behavioral explanation. Mary also touched on, well, there's some things about the brain that's actually unique in terms of sleep. When we're awake and in sleep, there's two different stages. Mary mentioned, I believe, the rapid eye movement or REM sleep, and non-rapid eye movement or non-REM sleep. And in terms of the brain, we can actually look right here to the left. This is EEG, electrical recordings from the scalp. But when we're awake, we're processing information. Hopefully you all are doing that right now. Some of this might be getting encoded in memory, retained later on. And this is what the brain tends to look like. We have these, kind of fast frequency alpha, beta activity. But as we start going into this first stage of sleep, where we're kind of drowsy, we're easily awakened, we're not really encoding memories. If I said, hey, Miriam, right? You would, I'm looking at Miriam smiling, you would be awakened, right? So we're easily awakened, not much memory encoding, but we see the brain waves are starting to get a little bit slower. And as we keep getting deeper into sleep, this kind of stage 2 or light sleep, we start to see our heart rate go down, our body temperature decrease. And this is really a stage where we see these signatures of sleep spindles and K complexes. Here, these signatures, and some memory consolidation is already going on here. We have the hippocampus, important in the brain for encoding memory. And that's kind of the flash drive of the brain. And these memories can start moving to more long-term storage in more of the frontal cortex of the brain. And when we think about PTSD, trauma processing, very, very important activity. And now we start seeing, as we go deeper into this stage 4 deep sleep, we see these 1 to 4 cycle a second, really big delta waves. And this is where we tend to see a lot of restoration happening with growth hormone release. We have tissue repair from the day. Our immune system gets ramped up. And this is a really restorative stage of sleep. And now we transition to that REM or rapid eye movement sleep. And although we can dream in other stages of sleep, this is where the majority of our dreaming sleep tends to happen. We're also completely physically paralyzed normally, so we don't act out those dreams, jumping out of windows, punching bed partners, except for our breathing muscles are not paralyzed, and also very, very critical for memory consolidation. So we have behavior, we have the brain, these various states we have, But we can also talk about sleep in terms of how is it structured. This is the time course, something called sleep architecture. And this becomes really clinically important when we talk about some of the effects of disrupted sleep for potentially your clients. And that's that we don't sleep in, now we're going to get all of our light sleep, then we go and get all of, we go to deep sleep. We actually cycle through during the night. Excuse me. So you can see here, starting with wake, and we start to drop into these light stages down deeper, deeper, until we get this deep sleep here. And then eventually we get into our first cycle of rapid eye movement sleep. Down here, if it's about 11:30 to 1 a.m. in this participant, it's about 90 minutes on average that it takes to cycle through one of these stages, and then back up through light, down into deeper, deep sleep. We go back into a stage of REM, and then we repeat again, maybe an awakening. And this can happen about, 5 times during the night to get about 7.5 cycles. And importantly, we see the majority of the deep sleep tends to happen in the first half of the night, with that rapid eye movement dreaming sleep happening in the later portion of the night. And so if you think about, let's say, trauma-related nightmares, you think about breathing-related difficulties, things that tend to fragment sleep, we actually have to start over again to get these deep restorative stages. Okay, so we can talk about behavior, we have the brain, and we have the time course of sleep stages. And now, also very important clinically, is what actually regulates sleep. And in the field of sleep medicine, we've really figured out there's these 2 processes involved in regulating our sleep and our wake. One, process S, this is really about building up sleepiness. So let's say here you wake up in the morning, the sleepiness you built up is burnt off. And then over the day, let's say if you're sleeping for 8 hours, it builds up, up, up. And ideally, we want the sleepiness to be at its maximum when we're physically getting into bed. That's very important when we think about something like treating chronic insomnia. And then if we fall asleep during the night, we actually burn that off, that sleepiness, 7, 8, 9 hours, whatever it is. And then when we wake up, the cycle repeats itself. We build it up, we go to sleep, down again, kind of rinse and repeat. That is what we can call sleep drive, right? This buildup of sleepiness. And this pairs with the second process, which is our circadian rhythm. Circa meaning about, around, dia, a day. These are rhythms that are about 24 hours, our circadian rhythm. And this includes things like core body temperature, melatonin. If you've ever heard some of your clients talking about they're using melatonin supplementation, stress hormones like cortisol. And importantly, these are all regulated through what we can call time givers, or in German, Zeitgebers. And does anybody know what is the main time giver that's kind of coordinates this 24-hour pattern in our body? Does anybody know with sleep wake? I'll give you a clue. There's a picture of it on the slide. Sun. I heard somebody say the sun very quietly. Is that right? And so that is correct, whoever said that. So the day-night cycle, and in particular sunlight, is the most potent time giver. It goes into our eyes. There's the master clock, the suprachiasmatic nucleus, and this has connections through our entire body. But that's why when you hear those sleep hygiene recommendations about screens and about blue light, it can, since the advent of artificial lights that we have, it's a big change for us. We're used to synchronizing to the day-night cycle. But this then becomes really important when we talk about, okay, how does this impact the sleep of the people that you work with? So if we talk about this buildup of sleepiness, the main chemical here is this chemical called adenosine, right? The primary sleepiness signal we have builds up in this frontal region of the brain. And if this was earlier in the day, I would hold up a little mug and say, does anybody know what is a very popular chemical that we use to combat adenosine, increase alertness? What do you think?
Caffeine.
Okay, coffee, caffeine, tea. So this magic molecule right here, and if you flip it around, you can see that this shape is very, very similar to this side chain of adenosine. And so what caffeine's actually doing is it competes and it binds to the receptors that recognize adenosine. And so it tricks our brain into thinking we haven't been awake as long as we have. We haven't built up that adenosine that would normally signal sleepiness. And then, you know, for those of us who have messed around with caffeine, if you have a bunch and then it has totally been metabolized, we then get this crash, right? This crash of sleepiness because we've built up adenosine that's still there, but now it combined. And this is also why things like caffeine and napping, which can momentarily, temporarily burn off some of that sleepiness that we've been building up. That's why that's one of those sleep hygiene recommendations too, because it can make it more difficult to fall asleep. It can, let's say you take an hour-long nap, now it takes maybe another hour to build up the same amount of sleepiness. So we're delaying the time it's taking us to fall asleep. So any questions about any of this so far? This is kind of building the foundation that we'll then build the clinical stuff on later. Okay. I will take that as we're okay. Now, circadian rhythms, we won't go too into it today, but this is highly genetically predisposed. So you'll hear of people who are night owls, people who are morning larks. I don't get tired till 3, 4 in the morning. I'm getting tired at 7, 8 at night. And this can really interfere with people's lives. It's a circadian rhythm sleep disorder. We'll mention it later, but this is the chronotype is what it's called, the kind of behavioral manifestation of our underlying tendency for a circadian rhythm. What you'll probably see more frequently when you talk about sleep with your clients are things that affect the circadian rhythm directly, things like melatonin that you can have over the counter, things like a sleep hygiene recommendation about the timing of exercise. Why? Well, that has a direct impact on our core body temperature. And as we'll see, we actually need to drop our core body temperature by a few degrees Fahrenheit to be able to initiate sleep and to maintain sleep during the night. And there's nice little tools and tricks we can use to not only increase relaxation. Let's say if your client is, you know, PTSD, stressed, they have anxiety, a warm bath is not only good for relaxation, but when we get out of the warm bath, we would think, well, that increases core body temperature, right? But we're actually rosy and we're flushed, and that actually dumps our thermal heat to the environment and it plummets core body temperature. So this can be one of those strategies you maybe have never heard of, but before bed, a warm bath, a hot shower, it actually increases relaxation, lowers core body temperature, and sets us up more for being able to fall asleep and stay asleep more soundly. Okay. All right, much more to say, but we won't spend too much time there. And now I believe it was Mary who already mentioned a couple of the functions of sleep. So I'm just going to throw it out to you all. When you think about getting restorative sleep, what is sleep doing for us? What are some of those functions that you've heard are very critical to sleep?
That you can think clearly? Is that what you mean?
So there's
Like,
some, yeah, definitely. In other words, what's it given us? And so definitely a link between cognition, our ability to think, right? To be able to remember and to attend. Absolutely. What else? See, as a trained clinician, that's one of my skills. I can totally wait. Sorry, go ahead.
Oh, it gives us energy, right? You have the energy, you have motivation, you feel like you can do things. Kind of gives you this whole mindset, that energy, I think.
Perfect. And that's a complaint that you'll hear often is I'm so fatigued. I don't have the motivation. And in PTSD as well, like, what are you doing? Prolonged exposure? You're doing CPT, EMDR. You need some of this restoration to be able to engage. So that's critically important. Corlin has processing emotions. I'll go ahead and just say that can be huge, right? Processing and regulating our emotions. There's a huge neurobiological literature on this. We know the mechanism, or we think we do, which is a very similar mechanism in trauma frontal to limbic, this kind of feedback loop. But in post-traumatic stress disorder and in borderline personality disorder that I also work with, extremely important for regulating and processing emotion. Also that cognitive piece, but consolidating and retaining memories. Sleep has a critical role for this. And if you're doing treatment and therapy, that's a very, very useful thing for the clients to be able to have on a daily basis. And again, cellular repair, right? Tissue damage. And this is something that is pretty new. Back in 2009, we didn't used to think the brain had its own lymphatic system. We didn't know what was going on, but we actually figured out that it does. It's called the glymphatic system, for the non-neurons glia, which means glue. But actually, sleep has a critical role of when we sleep, the space between the neurons, between the brain cells increases. And sleep is basically serving as a dishwasher for the brain. So we flush out these toxic metabolites that we've built up during the day. And a few of those key metabolites are beta amyloid and the protein tau, which, if any of you have heard of the molecular mechanisms of Alzheimer's disease, are directly related to that pathology. And so we've known sleep disruption and neurodegeneration have gone hand in hand for decades now, but this gives a clear mechanism about why that might be the case. So literally, when we're getting a good night of sleep, we are clearing out all of this waste of the brain. And if we have disrupted sleep, it's like we haven't really done the dishes, right? There's still all that film, and that's some of that lethargy, that cognitive impairment. And then, like we've said, energy, motivation, alertness, concentration. There's much more, but these are just kind of a few of the key functions that sleep is giving us. Okay. And then we're almost done here with the basics of sleep, but I'm just curious, first thing that comes to your mind, what you've been told since you were a child, how much sleep do you need?
7 to 9 hours is what they tell us.
Oh, somebody's actually up on the literature. Okay, well, that was a spoiler. I wanted they no, it's fine. Regina, was that you? How dare you?
I should have just been like this.
No, that is absolutely perfect. And so what I tend to hear, I would say 9.5 times out of 10 people, it just comes 8 hours to their mind. That's the belief. That's what they think they need. Back in 2015, this is held up, a meta-analysis of sleep time duration recommendations. And you see here for adults, the recommendation is about that 7 to 9 hour sweet spot. But importantly, this may be appropriate, maybe 6 hours, maybe 10 hours. But when we start getting 6 hours and less, or 10 hours or more, 10 hours or more can have some health concerns that go along with it. But on average, this tends to be associated with just a whole host of difficulties. You kind of name it, from cancer to obesity to cardiovascular disease to just an early life. Short sleep really predicts a shorter life. But what I like to tell people too is, I wasn't in these studies. I bet you weren't in these studies. And so part of working with sleep is figuring out, where is your client's sweet spot for the amount of sleep that they truly need to feel alert and refreshed the next day? Because when we deal with something like chronic insomnia, really stressing about I'm not getting 8 hours can be a huge barrier to getting refreshing, restorative sleep. So, okay. Any questions, any comments before we actually get into, well, what are we talking about when we talk about sleep disorders? Anybody have anything, questions at this time that would be useful?
This is Mary Martineau again, and I work with the geriatric population, with older adults. And I just noticed, the numbers for older adults can be so much longer or so much shorter. And I find people are so obsessed about whether they're getting enough sleep or not. And again, that's very stressful for them. Yeah. And talking about maybe you need less sleep because you're older. What's the physiology of that?
Yeah, so it's a great question. And as it turns out, it's actually a misconception that older adults need less sleep. Actually, the literature suggests that they need about the same amount, and 7 to 8 hours is kind of the recommendation. What it tends to be is there's neurodegeneration, there's other health concerns that actually get in the way sometimes of obtaining that solid consolidated amount of sleep. And so there's a number of things that can interfere, but the kind of key thing to know is it's not that, oh, I'm 72, I just need 6 hours. The evidence suggests that may not be the case. And if they can sleep longer, that would be ideal. But again, health concerns, there's chronic pain, there's a lot of things that can get in the way. It's a great question. I'm really glad you asked that.
Okay, thank you. Can I just ask one more really quick question?
Yeah,
Does
absolutely.
it have to be consolidated? Can it be, 5 hours here and then another 3 hours with the break in between, or?
Yeah, it can be. And so the kind of devil there is in the details. So what we don't want is multiple awakenings. Like 5 hours of consolidated sleep, that's very likely to be restorative. And if there's another 3 hours, that's okay. If it's in the afternoon as like a nap, well, you're going to be burning off a bunch of sleepiness. That's going to make it really challenging to have a kind of consolidated, predictable sleep-wake schedule. And when we're talking about older adults, napping comes up a whole lot. That's a whole different conversation. The short answer is possibly. The ideal scenario would be to have as consolidated chunk of sleep as you can get. The other thing here is there's this siesta, this kind of dip that all of us have in our circadian rhythm around lunchtime. It's actually independent of food. We all experience it even if we're fasting. But cultures that do that siesta nap, right? Some of those cultures, that actually proves to be very, very useful, as it turns out. But that's not like a 3-hour chunk. That's about an hour, hour and a half. So anyway, much more to say, but I'll kind of stop there.
Okay, thank you.
You're welcome. Anybody else before we shift into sleep disorders? Okay, let's go ahead and dive in. So I won't just do the open thing, what is it? But we talk about insomnia just like we talk about sleep. If we go to the Wisdom of Fight Club, when you have insomnia, you're never really awake. You're never really asleep. You're never really awake. If we go to maybe a more authoritative source, we have the International Classification of Sleep Disorders. And what insomnia is, it's this difficulty with falling asleep, with staying asleep. There's something about the duration, the total sleep time. We just mentioned consolidation. Is it interrupted, or sleep quality? This is really important that this occurs despite adequate opportunity and circumstances for sleep. If you're working with somebody that says, I just feel so tired, I'm so fatigued, and you're like, well, when are you waking up? Oh, 7 a.m. every day. Well, when are you going to bed? Like 2:30. So we're having 4.5 hours of opportunity for sleep. So a really critical question is, are you giving yourself 7 hours, 8 hours of actual time to have sleep? If so, if you still have this difficulty, now we can start thinking about something like insomnia. And like most things we talked about, it results in some form of daytime impairment. When we look at the prevalence, it can almost be shocking here. So 1 out of 10 people that you bump into out on the street, not just have this difficulty, but have insomnia that's been lasting 3 months or longer. 1 out of 10. If you talk about insomnia less frequently, difficulty, about 1 out of 3 people tend to experience this. And this can be in isolation. It can occur, it's very common in obviously PTSD, depression, anxiety. We've talked about chronic pain, substances, caffeine, cocaine, nicotine. All these things can provide the answer to why, okay? We have problems sleeping, but why are we having difficulty? If we shift to the DSM-5, I like little pithy mnemonics. You can think about insomnia as difficulty falling and staying and waking, and 3 despite opportunity. What that means is it's difficulty initiating or falling asleep, difficulty staying asleep, maintaining sleep, or waking up too early in the morning, and then there's a difficulty falling back to sleep. So falling, staying, and waking. There's nothing magic about these numbers, but clinically, we like to think that this happens at least 3 nights per week for 3 months or longer, again, despite that adequate opportunity for sleep. Okay, this is the clinical definition of insomnia disorder. Anybody have any questions about that? What is insomnia? When your clients talk about that difficulty with sleep, any questions about the clinical definition here? Okay. All right. I think we got it. So now we'll shift to the second major condition when we think about PTSD and trauma, nightmare disorder. Okay. So again, the DSM-5, we can ask the question, well, what is a nightmare? Okay. We won't take the time to do that, but you can kind of think about, well, if you had to define a nightmare, what would that be? And so clinically, what we're looking at, it's this repeated occurrence of these dreams that are prolonged, they're extended, they're extremely, we can say, dysphoric, a lot of negative emotions, a lot of stress. And importantly, unlike something like a night terror that you can hear about often in children, where we wake up, we're inconsolable, but there's no memory of the dream. Nightmares, when you ask people, they're like, yeah, I remember that we well remember these when we wake up, and they're usually associated with threats to, you know, our survival, somebody else's survival, our security. And this generally occurs during the second half of the major sleep period. And I'll just throw it out there. Why do we think that might happen during the second half based on what we've already heard today? This can be a little pop quiz.
Didn't you say there's more REM sleep second half of the sleep cycle?
There you go, Morgan. That's right. And so when these things start happening, again, this understanding of the basics of the sleep biology and physiology, that can really start to make sense of when your clients are telling you they're having problems, let's say falling asleep, or they're waking up too early and they can't get back to sleep for insomnia. That's really likely to hit that REM sleep. And if we know REM's important for memory consolidation, all these other things, we can start to anticipate the kind of symptoms that they might be telling us. So, right. We tend to see this during the second half, and on awakening, if you've ever had clients with PTSD describe this, very alert, very aware, and that hypervigilance can kick in, and that can make it very difficult to fall back to sleep after a nightmare related awakening. So in terms of severity, we have acute, that's it happens, but it's, you know, less than one nightmare a month. Subacute, it's more than one per month. Yeah, I'm sorry, it's been happening for more than 1 month, but less than 6 months. And then persistent, if this has been happening for 6 months or longer. And sorry, with acute, it's been happening for 1 month or less. And then severity here, mild, less than one nightmare per week. In adults, the prevalence there is about 6%. Moderate, more than one nightmare a week, but it's less than nightly. And then severe, we're having at least one nightmare each night. And in adults, that's about 1 to 2%. In PTSD, depending on the number of index, traumas, the severity, that can get up to 70 to 90%. So extremely common here. Okay, these ones I'm actually not going to use our time for, but I want you all to have these slides when I send them, because these are key things that can come up when you start asking about sleep. One of the main ones to know is obstructive sleep apnea. And what this is, the questions here is, do you tend to snore? Have you had a bed partner that's told you that you stop breathing during sleep? Okay. And so what this is during sleep, if you've never taken anatomy or seen this tongue is a huge muscle that we have, right? Laying back. And so as we're breathing, especially if we're laying on our back, this is repeated episodes of either complete obstructing of airway, which is called apnea, or partial obstruction, which is hypopnea, during sleep. Okay. And so these events of no breathing can be 10 seconds or 60 seconds, 1 minute or more, when we have the tongue, the soft palate, the soft tissue collapses back and pinches off the airway. If you've ever, snored, if you do it now, that sensation, that's air vibrating against soft tissue, right? So this pattern is and then there's still effort to breathe, but there's no breathing. And I'm seeing some faces there. That reaction, that is terrifying as a bed partner. They just stopped breathing. And then it can be 10 seconds, 1 minute, and then, right, this big gasp. Our brain wakes up, we pull the tongue out of the throat, and then this can happen multiple times each night. And so clinically, when you ask, are you having problems with sleep? We'll talk about an assessment measure. Do you snore? Has anybody asked if you've held your breath? Obesity can predispose here, but clinically, excessive daytime sleepiness. I'm not just tired, but if I gave myself a chance, I would fall asleep almost immediately. Why do we think excessive sleepiness might be on the menu if this is kind of the clinical picture during the night?
Well, not breathing's not good for your brain, but also does it kind of wake you up? Do you kind of not, maybe you don't get into REM? I don't know. That just can't be good for you.
Very good. It can't be good for you, and that is true. And so just what you mentioned, when we think about, well, why do we even need to know about sleep architecture? If you're waking up multiple times, and sometimes this is 10, 20, 30 times an hour, what we're doing is we're really preventing the deep sleep and the REM sleep, right? All across the night. So we're obstructing, we're popping up into wakefulness. We're never allowing our brain and our body to get down into these restorative stages. And as we know, those are the stages for increased restoration. Obstructive sleep apnea happens a lot in REM sleep because all the muscles are paralyzed, the tongue and the soft tissue in particular. So anyway, if you hear your client has a sleep disruption, they have PTSD, a great assessment question is about snoring and holding their breath. And yeah, it can't be good for you, and it's not good for you. There's a lot of complications mentally and physically from sleep apnea, stroke, heart disease, depression. And the treatment there is continuous positive airway pressure, or CPAP. And all that is it's using the air to mechanically hold open the airway here so the tongue can't collapse back. And this happens all the way during the night. And so it allows the brain and the body to get that restorative sleep, to get into those sleep stages. And it becomes this virtuous cycle. All of a sudden they have energy, their mood improves, and sometimes they actually have the energy now to lose weight. And if weight's a big factor, that actually can be curative in some cases. This can be an incredibly life-saving therapy. I just wanted it in the slides because it's a key differential when you're thinking about insomnia. And also too, nightmares, when they're waking up, stressful dreams. An interesting question is, well, what are those nightmares about? If you ask, are these about drowning? Are these about suffocating? Are these about choking? Yeah, that can suggest sleep apnea too. If they're like, no, it's really about the trauma. Okay, that's pretty clear cut. But also difficulty breathing throughout the night can lead to nightmares as well. Okay, I'm not going to cover these. These are the circadian rhythm sleep disorders. Delayed sleep phase disorder. It's nice to ask about their biological sleepiness. If you didn't have to wake up for school at 7, if you didn't have the family obligations, when would you choose to sleep? Right. And if they're saying, no, I actually don't get tired until 2 or 3 in the morning, but they have to wake up at 7 a.m. for a school start time, that actually might be the cause of the sleepiness and sleep disruption, not necessarily insomnia. If they were on their own biological schedule, they could sleep just fine, but it's a mismatch between their biological rhythm and the social rhythm. Okay, so you will have your diagnostic criteria here to look back into treatment for a delayed sleep phase. It's actually using bright light. It's using that time giver of the sun artificially to advance the circadian rhythm. I won't get into it here. Restless leg syndrome. A question you can ask is, well, do you have this irresistible urge to kind of move your legs, an uncomfortable sensation at night? That can also disrupt sleep. This would be an example of, if you had that, you would refer out to a sleep clinic because in terms of treatment, we have iron, right? Anemia, check your ferritin, but oral or IV iron can be very, very useful for restless legs. It may not be frequent in your practice, but it can be something if your clients are complaining about these uncomfortable, creepy, crawly sensations, that can suggest restless legs. So we have about 45 minutes. We'll get through this. Any questions at this point, or should we just kind of, I think we'll keep moving on here. Okay. Sleep in PTSD. Here's the main thing, if there's anything I want you to take away. Why should we think about integrating and treating sleep in PTSD? There is so much evidence associating sleep disruption to increase risk for suicide. Okay. So if you have nightmares occasionally or frequency, that can increase risk by 60 to over 100%. Of individuals who attempted suicide, about 3/4 having difficulty falling asleep, 70% difficulty staying asleep, and almost 70% reporting nightmares, with nightmares being associated with a 500% increased risk of suicidality. So a really strong risk factor here. And as we may know, PTSD, also borderline personality disorder, they're among the highest risk for suicide across all mental health disorders. In PTSD, it's about 70%, in BPD, about 50%, meeting criteria for insomnia, nightmare disorder, or both. So this is highly prevalent. The first step is just asking about it, okay? And so importantly, there's evidence that if you target insomnia, CBTI will talk about it, meaningful reductions in suicidal ideation and depression. If you combine treating insomnia and treating the nightmares, we see those reductions and depression and also PTS severity. This was in a study of combat veterans. And so this is just to say that part of the reason to have this talk today is if this can be on your radar to ask, it literally can be life-saving. And in working in the VA and in working outside the VA with, veterans and civilians with PTSD, it's such a critical component of treatment. And this I've heard a lot, and this is one of those things to walk away to. Evidence suggests that doing PTSD treatment, it can definitely improve the symptoms of sleep disruption. But Edna Foa and other people who have done this research, they find that if you follow these people over the long term, the insomnia and the nightmares are very unlikely to remit clinically without directly targeting sleep disruption. Okay. And so what that means is it can improve, but insomnia and nightmares, they tend to break off into their own little monsters, right? These are learned patterns. These are very common over months and years and decades, and they require these targeted treatments that we'll talk about today to fully have them remit. So big takeaways, this is very, very common. We need more folks like yourself to be asking about sleep and treating them. They're unlikely to go away unless we treat them directly, and this is worth our attention. It literally can save lives. I like this quote from Sporemaker and Montgomery in 2008. This was a review of, is sleep secondary in PTSD or is it primary? And after their review of the literature, they just say, with findings such as these, it's neither ethical nor cost effective for mental health professionals to neglect sleep disturbances in PTSD treatment. Sleep treatment should and can be incorporated into any kind of PTSD treatment, whether pharmacological or cognitive behavioral. So very strong words, but I couldn't agree more. Here's the key barrier. It's well known in the field of behavioral sleep medicine, we don't have enough clinicians trained to assess sleep, to do the differential diagnosis, and in particular in these evidence-based treatments for insomnia and nightmare disorder. So I'm very glad to have the opportunity to talk to you all today, and that's where we're moving to right now. So in terms of assessment, you will have these questionnaires. I would say, even as we'll talk about at the end, the PCL5, this is very likely to come up in your work with people with PTSD anyway. But in case, this is an incredibly common, incredibly useful instrument, the Insomnia Severity Index. Last 2 weeks, I also use it weekly when I work with folks clinically. What is the difficulty falling asleep, staying asleep, waking up too early? Those are your insomnia symptoms. None to very severe. Satisfaction with sleep. Excuse me. How noticeable do you think this is to other people? Worry and distress about sleep, very important with the relaxation and other tools we'll talk about. And how is this interfering with your daily functioning? So you can track that over time. Here's the criteria all the way up to severe. That'll be there for your reference. For sleep apnea and insomnia, there's this Epworth sleepiness scale, a really quick measure, but not just fatigue, but how likely would you be to actually fall asleep in these various situations, watching TV, lying down in the afternoon. A lot of people with insomnia, PTSD, if you say, do you nap? They'll kind of laugh. Like, I haven't been able to nap for decades, right? Insomnia as well. If they're fighting a lot of daytime sleepiness, that could suggest, is this a breathing related disorder? Is sleep apnea on the menu? Is something else going on? This can be very useful to track week to week. Here are the kind of clinical criteria here. I won't get into this, but pre-sleep arousal, what's going on physiologically, what's going on mentally, this can really point directly to targeted treatment options. If it's physiological, how do we use some of those relaxation tools? If it's, I can't shut off my mind, I'm so mentally alert, I can't stop worrying, let's start getting those tools to how to address rumination. This can be very useful if they're struggling with those difficulties. This is the cognitive part of CBT for insomnia, all about these beliefs we have about sleep. We've already mentioned one today. I need 8 hours of sleep to feel refreshed and function well. Here's a really concerning one clinically when I hear it. I'm worried that I may lose control over my ability to sleep at all, right? I need sleep meds. I can't do anything. I'm hopeless. Another one is I can't ever predict when I'll have a good or a poor night of sleep. That one there, is it going to be a night with nightmares? Am I going to be able to fall asleep? And as we'll talk about, tracking sleep with a sleep log really can give relief to this sense of it's not predictable. I can never tell. So very common sleep related beliefs that tend to get in the way of refreshing sleep here. These are just questions for sleep apnea. We've talked about snoring. Are you tired? Has anybody observed you holding your breath during sleep? Do you have high blood pressure? I typically don't ask questions 5 through 8. A lot of people don't know their neck size circumference just off the off the cuff, right? But this can give you a good sense of the risk for a breathing related disorder happening. Really useful questions. And then in particular for nightmares, this fear of sleep inventory can be extremely useful about very specific behaviors that you can potentially modify. I was afraid to close my eyes, right? I tried to stay as alert as I could while lying in bed. A lot of anxiety about fearful of letting down my guard while sleeping in the context of trauma. And so this can really point to trauma-specific interventions that we can consider that may be on the menu for your specific person that you're working with. As I mentioned, if you do something like the PCL5, well, as we see, we're going to have an indication of repeated disturbing dreams and also trouble falling or staying asleep. It's right there in the diagnostic criteria. So this might be something you're already monitoring. Here is one of the tools, and this in terms of behavioral sleep medicine and sleep medicine, this is the holy grail, right? This is the golden ticket. If you're going to work with me clinically, you are going to be bringing in your sleep log, okay? There is a number of sleep logs that you can use. Some of them, it's just a graph and you're writing numbers and you're plotting them. That's something I do on my own in this Excel sheet that I'll also be sending you that automatically calculates all these useful variables. But clinically, I found this to be the most useful, and it's a visual sleep diary. So you can actually see on paper the sleep pattern that's going on. And so all of you can cheat by looking at the example night, but it's actually worth going through to make sure everybody understands this. So here we have 2 weeks worth of data from Monday through Sunday to Monday through Sunday. Here's a place for the date. Across the top, starting here at this line is midnight. It goes all the way 4 a.m., 8 a.m., all the way here to noon, 12 p.m. right here in the middle, 2 p.m., 4 p.m., 8, 11 p.m. here. And then as we hit midnight, we then wrap around to the following day, 2 a.m., all this, okay? Really important in the instructions, completing this around 30 minutes after the final awakening. If you have a nightmare, you're not to pull this out. It doesn't need to be that specific. Don't be perfectionistic with it, not during nighttime awakenings. The thing I love about this is I can get all the clinical information I need with 3 pieces of information. If it's insomnia, 4 or 5 if nightmares on the table too. Anytime you physically get down and into bed, I want you to put a down arrow. Okay, that's down into bed. Anytime you remember yourself actually sleeping, doesn't have to be exact, but you think, okay, I think I was asleep, go ahead and shade in that box. Okay, and anytime you physically got up and out of bed, not you were awake during the night, but you got up and out of bed, I want an up arrow. Okay, down into bed, you were asleep with shading, physically up and out of bed. And then if you have a nightmare, we'll go ahead and just put an N when you think you might have had it. Okay, that would be 1 nightmare. And in the margin, go ahead from 0 to 10 in terms of how intense that nightmare was for you. 0, not intense at all. 10, that's one of the most intense or the most intense nightmare I've had. And you can just put that to the left of the date. Okay, so I know that was a little bit quick, but let's actually go through this example night. So again, you can look down here and cheat, but you can try to play along. Let's say this was my sleep last night. Okay, before I had the meeting, what time did I physically get down into bed last night? And anybody can shout it out.
$10 p.m.
Okay, so I love that you gave that answer. So 10 p.m. would be right here on the corner. That would be 10 p.m. So what do you think now?
10:30.
Perfect. So I got down into bed at 10:30 p.m. last night. About how long did it take me to fall asleep last night?
Looks like a half hour.
Beautiful. So about 30 minutes to fall asleep. I remember sleeping from about like 4 hours, from like 11 to 3 a.m. What do you all think might have caused that first awakening that I had?
Nightmare.
Okay, so there's an N right there. I remember that awakening. I had a nightmare before waking up. About how long did I spend in bed before I actually got out of bed after having that nightmare?
Half hour.
Say it again.
About a half hour or 45 minutes.
Yeah. Good. So about a half hour or 45 minutes. And clinically, this is really useful because if you see a lot of time here, the question to ask is, what are you up to? Like, what are you doing in 45 minutes? I often hear, I'm tossing and turning, I'm getting pissed, I'm punching my pillow, or I'm just ruminating, or I'm thinking about the nightmare. This will be a key skill that we'll talk about with insomnia and nightmare disorder to break that pattern. But okay, so 45 minutes in bed, I got up. Let's say, as I know what skills we do, I'm doing some relaxation exercises. I'm actually kicking in that parasympathetic nervous system. And so about 4:15, I got back down into bed. About how long did it take me to fall back to sleep last night?
15 minutes.
Beautiful. So about 4:15, about 30 minutes, and I slept 2 hours, 4:30 to 6:30. It's kind of hard to see here, but I just laid in bed for about 30 minutes and then I got up and out of bed at 7 a.m. this morning. And let's say I was just so stressed out about doing this, trauma-informed care network presentation that after seeing a client, I just got back in bed at 1:45 for a nap. Took me about 15 minutes to fall asleep and I napped for an hour, got up around 3:05. This is just for sake of illustration. If you have clients that nap, that's how it would look during the day. So this is one night of a sleep diary. Once your clients get used to doing this, it takes literally 45 seconds, maybe a minute in the morning. But this is, again, the golden ticket of if you're going to work clinically. And I would recommend the first step, if you ask your client about their sleep and they're struggling, this is something you can do right away. You hand this to them and say, Well, let's just get a sense of the pattern of your sleep. What does it kind of look like night to night? And it can really start to provide a lot of rich information that, again, I will send you guys this Excel, send you all the Excel, and you can enter the information about, like, what time did you go to bed? Okay, this is in military time, 10:50. It might have taken you, let's say on this night, 5 minutes to fall asleep. And you can see how long you were awake during the night. Again, with this, that would be an hour and a half, roughly, 90 minutes there. What time did you wake up? Well, I woke up at 6:30 this morning, but then you'll see how many minutes was that before I wanted to wake up? Well, that was about 30 minutes before I wanted to wake up. And so what time did I get out of bed? Well, that would be about 7:30. Okay, so you just enter the date, you enter the data in this blue section, and then it's programmed automatically with Excel formulas that you'll get a lot of this clinical information. On average, how long did it take them to fall asleep? This person, 5 minutes. They were awake an average of 12 minutes in the middle of the night. They woke up about 14 minutes earlier than they wanted to. They got out of bed, about 15 minutes later than after they woke up. And this is a magic number here, sleep efficiency. I won't go into it too much, but clinically, this is the amount of time that you're actually asleep in bed compared to the total amount of time you're spending in bed. So 93% means 93% of the time that you're physically in your bed, you are asleep. When you're talking about insomnia, 85% and above is where we want to see you. 90% and above is ideal. Okay. Anyway, won't go into too much more, but this is the sleep log. You'll have the Excel if you want to calculate it. Importantly, because this will come up in our case example, any questions about how to read the sleep log, how to interpret it? I just want to make sure this is really clear, because this is one of the biggest things I want you all to take away from this presentation. Okay. I'm going to take that silence as it is crystal clear to every single person here. If it's not, there's my email here. Please feel free to reach out to me. This is an important thing. Okay, this is what we came for, right? We are now at the point where we can talk about, that's all great. What about the tools? Okay. CBTI, when insomnia is on the menu, cognitive behavioral therapy for insomnia is the gold standard, the first line recommended treatment before medications when we're talking about 3 months or longer. Here are the principal components. Stimulus control. Okay, we'll talk about the actual recommendations here in a second, but this is only going to bed when you're sleepy. Not when you think you should be in bed, but when you have sleepiness to fall asleep. I call this hitting the reset button. This is that tossing and turning, that 45 minutes of getting upset. If it's been, 15, 20 minutes, or more importantly, if your mind's just telling you we're not going to sleep right now, physically getting up and out of bed, breaking that learned association between the bed and the bedroom as a place for stress versus sleep and rest. We want to keep doing this pattern. It's incredibly powerful. That is hitting the reset button. Sleep hygiene, this is what most of us are familiar with, and we'll talk about it. Caffeine, nicotine, alcohol. How's your bedroom environment? Is it cold? Is it calm? Are you doing other things besides sleep and sex? How about environmental light? Critically important, but this is only one of 5 core components to CBTI. Okay. So stimulus control, sleep hygiene. This, you'll hear the term sleep restriction, which to me is, as a DBT clinician too, I don't like judgments, but it's a very ineffective way to say that. Let's say, so we're actually not restricting people's sleep, but let's say you're working with somebody with PTSD and they say, I'm getting 6 hours of sleep a night. Well, what we actually want to do is we want to match the time that this individual is spending in bed approximately to the amount of sleep they're currently getting. So we're not restricting their sleep. We're actually matching the bedtime more to their current time in bed. Why would we do that? Well, we want to break this association between being in bed when we're not sleeping. Okay. So if they say I wake up at 6, and I go to bed at 11 o'clock, but they're only getting 5 hours, let's say 6 hours, okay? You would just say they wake up at 6, you now have 6 hours of time in bed. You're going to go to bed when sleepy, but not before midnight for this first week. Midnight to 6 is now your window. And over time, if their sleep efficiency goes up, we're going to increase that time 20 minutes, 30 minutes, if that's looking good, to figure out how much sleep do you need. But again, it's breaking that association. Okay. And if anybody has a question as we go, feel free to shout it out. Relaxation training is a huge component. PTSD, absolutely, with hyperarousal, but we want to target the arousal in the body and also in the mind. And cognitive therapy, this is mainly about those sleep interfering beliefs. Okay. These things that can get in the way, a lot of education, we'll talk about it. So I'm going to blow over this. CBTI is the first line. There's been a lot of studies showing that compared to medication, CBTI tends to have similar outcomes. But over time, when you compare it, the medications, we get tolerance, they lose efficacy, there's side effects. CBTI is skill-based, and the skills tend to last for the rest of your life. So over the long term, it is the first line. In 2016, the American College of Physicians came out and said CBTI is the first line, which is a big deal because they're physicians, they're prescribers. The American Academy of Sleep Medicine on 3 different occasions, 2008, 2017, 2021, there's a consensus that this is the first line for insomnia. If you're interested in a deep dive of really being able to do this flexibly, this is the book that I would recommend. I have it back here on the desk, but a case formulation approach, how to do this flexibly. You'll have these slides. It's incredibly useful. So we've talked about it. Let's actually start doing it. So relaxation training, let's talk about paced breathing. So if you're willing to play along, go ahead and use your index finger, find your carotid artery on the side of your throat there. And what ideally you'll be feeling is a heartbeat. Yeah. And so what I want everybody to do is don't control anything. Just notice in this moment, you're not controlling your breath. Just notice what your heartbeat is like. Okay. And then now I don't want you to count breathing. There's nothing you're going to need to count. But just on the in-breath, go ahead and just take, kind of a typical in-breath that you would do. But on the out-breath, go ahead and experiment with making that longer than the in-breath, right? So sometimes you can think about breathing through kind of a big straw. And so we're breathing in and then out. Not forcing it, just kind of try to empty your lungs. And then when it feels comfortable, breathing in again at your own natural rate, and then prolonging that out breath, either through your nose or through your mouth. And as we do this a few times, I want you to pay attention if there's any difference in the rate of your heartbeat on the in-breath compared to the out-breath. So we'll just do this for a little bit. Okay, and when anybody notices anything, go ahead and just unmute and let us know if you noticed any difference on the in-breath or the out-breath.
My heart rate definitely slowed down on the out-breath.
Okay, so for Amanda, there's something about the out-breath where the heart rate slowed down. And you can just check in if that was your experience. Sometime if we're feeling pressure, it can be hard if we're a little anxious to notice a difference. But I mean, for Amanda, I would note that that would mean you're wired up as I would expect you to be as a human. Okay, so our breathing is very unique, which is the in-breath is paired to the branch of our automatic nervous system or the autonomic nervous system, which is the sympathetic branch, which is our fight or flight, whereas the out-breath is hooked up to the brake pedal, the parasympathetic, the rest digest component. So here we see in red, this is the electrocardiogram or heartbeats, and we can see in blue respiration. So as we breathe in, we see heart rate increasing. But as we breathe out, doof, 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 that slowing of the heartbeat. And then in, it increases, out, it slows down. So if you're running away from, let's say, you know, a tiger, some kind of predator, how do we tend to breathe? How would you tend to breathe?
Shallow.
Right. We're breathing here. We're using the chest muscles. Do we run away from people like, no, we don't do that. I'm seeing smiles. And there's a reason, because, right, we don't have the luxury of that prolonged out breath. And so when we're talking about hyperarousal, but also about nightmares, also about insomnia, by intentionally prolonging that out breath, we are directly signaling to our brain, we can't be that stressed out right now. We have the luxury of this prolonged out breath in this moment. And so when I do this skill, I'll actually take my finger and feel my carotid. It's been a rough session, stressful with 4 young kiddos during a pandemic, whatever it might be, let's say, in my life. But this is a very useful skill in the pre-sleep period, after nightmare-related awakenings, or just during the day. If tension, stress is on the menu. I wanted to linger here because it's a particularly powerful skill, because we all have our breathing. We're doing it anyway. It's just by controlling it in this way can really, you know, influence the nervous system in a way to promote relaxation. So in the time we have, I want to make it through often stimulus control and bedtime matching. It can be very useful to combine these skills. And this is what it looks like in terms of recommendations. So if you have one tool in the sleep medicine toolbox, it's going to be not just consistency, but holding a consistent wake time. So wake up at this specific time every day, set an alarm if you need to, and regardless of how much sleep you actually get out of bed within 5 minutes, 10 minutes after that alarm rings. This can seem very counterintuitive. What if it's a poor night of sleep? But like we know, I have people reframe this as, you're no longer having a bad day, you're building up adenosine, right? You're building up this sleep pressure. So for the next night, you're falling asleep more easily, and you're reducing the likelihood of waking up during the night. So this can be very powerful when combined with, now we're going to say you're only getting into bed when you're sleepy. Head nodding, that's not just tired, but like we did with that bedtime matching, you're going to set a bedtime window, let's say, but not before 11 o'clock p.m. But if you don't feel sleepy at 11, wait until you do feel sleepy. This is critical for insomnia, because if people think I should be sleepy at 10, but maybe biologically they're not sleepy until 11:30, that's setting us up for not being able to initiate sleep. We start, you know, tossing and turning, and that whole learning cycle starts. Also, this is one of the golden rules that is in the nightmare treatment that we'll talk about. It's an insomnia treatment. If we're not being able to sleep 15, 20 minutes, or we're not doing it right now, stop trying, okay? I've never met somebody who can will themselves unconscious, okay? Trying to sleep is the problem. And so get up and out of bed, even if it's wintertime and it's warm and cozy, but do something calming. We have those relaxation skills, diaphragmatic paced breathing, mindfulness meditation, reading, taking a warm bath, whatever it is for them, and then return to bed only when you're sleepy again. This is the reset button. But when we lie in bed trying to sleep, we're training ourselves to be awake in bed. It's incredibly important. If you see those gaps in the sleep log, this is one of the first things I want you reaching for, the consistent wake time and breaking that pattern. And if there's a lot of napping, this is what we've talked about. It can be okay, but if there's a lot of it, you're burning off that adenosine. You're burning off that sleepiness, prolongs the time it takes to fall asleep, and it can increase nighttime awakenings as well. Importantly, though, if they're somebody's a truck driver, somebody's a surgeon, she really needs to be up at this certain time. If it compromises your safety or somebody else's safety, naps are okay. Usually 15 to 20 minutes is where we want to see that. So we're not getting in those deep stages of sleep. That can be hard to wake up from it. Okay. All right. In the interest of time, I would love to answer questions about all this, but know that these are key recommendations. Sleep hygiene, I'm going to blow through pretty quick here. So we have alcohol, caffeine. Here's all of the things. 3 to 4 hours before bedtime. Caffeine, an incredibly long half-life. It takes about 10 to 12 hours to completely clear it from our system. So if you're getting into bed at 11, I like to see you stopping caffeine at 11, 1 p.m. at the latest. It can make a huge difference. Smoking, especially during those middle of the night awakenings, can be common. It's a stimulant. It's hard to go back to bed. Exercise can be variable. Again, that hits core body temperature, but everybody's unique. Sometimes that's useful. Experiment with it. Avoiding heavy meals. We have reflux, there's indigestion. A light snack can be okay. We don't want to be hungry, but we don't want to be too full. Sound, white noise can be incredibly useful for somebody if they will allow themselves. If they have a trauma history, if it's not threatening, they need to hear everything. Being able to have something calming and consistent for the mind to latch onto can really make a big impact. But avoiding intermittent noises, podcasts, TV, YouTube video, whatever it is, that can be very disruptive. Light, keep it dark. It's like a cave. Avoiding screens because it mimics UV light, to the brain. That impacts melatonin. Mattress, that's really not a huge thing that comes up for me unless it's really uncomfortable. But if there's chronic pain, a medium firmness can kind of help with that. And then temperature, this is a big deal too. If they're hot, our body needs to drop 2 to 3 degrees to fall asleep and stay asleep, which is why we almost always find it easier to fall asleep in a room that's too cold versus a room that's too hot. So is a fan on? What is the thermostat at? This can seem kind of cold, 65 degrees, 67 degrees. It can make a huge difference with sleep. Okay. And then finally, cognitive therapy. We've talked about these beliefs about sleep, but a lot of this is the kind of standard CBT stuff, right? Behavioral experiments. We can do pros and cons, different safety behaviors, checking perimeters. A lot of mindfulness and acceptance and commitment therapy techniques can be really useful. We don't need to challenge the thoughts, but can we notice them arising? MI, right? There's ambivalence for change, Socratic questioning, keeping a thought record. All of this stuff can be very useful. And then just scientific information. You're not lecturing, but it's just maybe pulling out that slide about they need 8 hours. Well, maybe 7 hours are okay. Maybe 6.5 can be fine. You're a unique individual. You can talk some of that stuff through. Okay. All right, I'm going to move into this because I want to cover nightmares. 2 key things for nightmare disorder, just like CBTI for insomnia, imagery rehearsal therapy, or IRT for nightmare disorder is a gold standard. Barry Krakow is a psychiatrist. Him and his colleagues have done some of the primary work on this. These 2 articles really lay out the whole foundation of what this treatment is about, step by step in the protocol. As an overview, you can do this in groups, 4 2-hour groups. I do this individually as well. It can be about 6 sessions, 8 to 9 hours, sometimes of total therapy time. But this is really about education of how nightmares can lead to disrupted sleep. In particular, the relationship between nightmares and insomnia, and why nightmares actually stick around so long after the trauma exposure. Okay. As is in the title, imagery rehearsal therapy, using the imagery system in our brain and overcoming difficulties with imagery. Sometimes in PTSD, those intrusive symptoms, those emotions, those memories, we've so pushed those down and avoided them that it can be really hard if you say to your client, imagine a red ball. Just close your eyes and imagine a red ball. What do you see? Like, this is an activity you can do. For some people, it's right there. They can visualize it. Other people, they got nothing. So we really have to overcome those difficulties. There's a identity here. I'm just somebody who has nightmares. I'm a nightmare sufferer. We really work to change the identification to maybe I'm actually capable of not having this. If you tell somebody I do work with nightmares, they think, how am I going to change something? I'm unconscious. That sounds crazy, right? And it's like, yeah, kind of, but it works, which is crazier. And so that's what I want to talk about here. This is the key. It's changing a nightmare into a new dream by actually writing out the nightmare script, rewriting that nightmare into something that's a changed dream, at key points and then rehearsing this new dream, 15 minutes, 20 minutes each day. Closing your eyes, imagine actually going through it and continuing that rehearsal until the frequency and the intensity of the nightmares have decreased. Okay. Now, importantly, a variant of IRT that is specific to trauma-related nightmares is called exposure, relaxation, and rescripting therapy. We have way too many acronyms in this field, but ERRT. Okay. Joanne Davis, this book lays out all the principles about how to do it. But in summary, this is taking IRT and really shaping it specific for individuals with trauma-related difficulties. So first session, it's all about education and relaxation. Nightmare impacts on our body, our actions, our thoughts, right? How nightmares impact our sleep habits. This is why I love this treatment so much. It incorporates CBTI techniques. It merges what we know works from insomnia, and it incorporates that while we're targeting the nightmares. And then we do a relaxation skill, progressive muscle relaxation, physiological tension. Okay. Session 2, it's very much like a intro trauma. If you're doing PE, CPT, you talk about trauma, PTSD, you talk about nightmares being a symptom of PTSD, how common it is, 70% more, they don't feel like they're alone. And this is something you don't get in IRT. It actually talks about the research about why do we think nightmares develop? We won't get into it right now, but processing emotion, that's a key function of sleep, and it's a key function of the treatments during the day. But we actually need to process some of this emotional component of the nightmare. There's a reason that disturbing dreams, that's one of the intrusive symptoms. It's just happening during sleep while we're unconscious, not while we're awake. This notion of mood matching, it actually seems to matter if we're really anxious and tense and fearful before we go to sleep versus in a more relaxed state. It's almost like the soundtrack of our dream. If it's intense, it's a horror movie, that tends to be more likely for a nightmare, whereas it's more light and relaxed. And then just like IRT, disruption to our imagery system, that's part of why these nightmares can develop. Okay. Now we add visualization, that visual component to progressive muscle relaxation. This is the key, just like IRT, but now we're going to write out and we're also going to read the most upsetting nightmare we have. In imagery rehearsal therapy, they're like, no, start low, let's see what happens. In this is where the exposure comes in. So usually that's related to the index trauma. And the key thing that I love in IRT, it's change the nightmare any way you want. Just what feels good, just change it to a new dream. In ERRT, you're going to change your nightmares specific to these trauma themes that we see about safety, trust, control, esteem, intimacy. Those things you would be working on clinically, these things tend to come up all the time in trauma-related nightmares. And so you work with the client to change and rewrite, rescript the nightmare, emphasizing these changes to these trauma-related themes. You check subjective units of distress. What's your SUDS like before and after? You talk about habituation. They read it out loud again. And now we talk about paced breathing, the skill that you all know now. Feel your carotid, do this stuff, do it before bedtime. Mood matching, right? This whole treatment hits all of those theories of nightmare development. And now, troubleshoot. Was there difficulties? You couldn't do the imagery. Importantly, did we rescript too much? Was this new dream too different from the nightmare? We want the core components to be there. That tends to be very important, but we want this shift to happen. We kind of troubleshoot that. Is there a new nightmare? Okay, if they have additional ones, some people only have that one. The cool thing is if you start with that most distressing dream, it tends to generalize to other nightmares too, which is nice, right? And now we teach mindfulness. This session, treatment review, this is a practice, but these are skills for life. If this happens again, you now have the tools in the toolbox. That is the 2 gold standard treatments. Obviously, there's much more to say. If this was a full day training, we would walk through those components. We're probably not going to have time for the case example in detail the way I would want it to be, but I do just want to say, so this is Megan, not their real name. And so 16-year history of sleep disturbance, fear of falling asleep, difficulty maintaining a sleep associated with trauma-related nightmares. Okay. Prior diagnosis, MDD, GAD, and PTSD. Routinely awakening 3 to 4 times after sleep onset due to trauma-related nightmares. So sexual assault, emotional trauma from her father, multiple suicide attempts, lost her job in her apartment, had to move back in with her folks. She tried prazosin for nightmares, trazodone for insomnia, venlafaxine. She was doing ketamine and THC for the nightmares. Ketamine was a new one for me clinically. She's doing a lot of stuff. She's keeping the room cool, avoiding heavy meals, sleeping with a therapy dog. So ketamine, THC, but since age 10, that's what's happening, okay, for her. So sleep treatment to consider, just shout it out. What do we think if this was your client? What sleep treatment or what protocol might you reach for and why? I'm just going to answer it in the interest of time. So trauma-related nightmares are huge here. There's also symptoms of insomnia, but we need ERRT right now, not just nightmares, but trauma-related nightmares. And so this is her sleep log for the first week. Okay, this is why it's important to be able to read one. I wish we had more time. I know we don't. But in terms of just note to yourself what you see in the sleep log. Down arrows, shaded boxes is sleep. These white things are gaps. Ends for nightmares. I'll just tell you what I saw. This is a very irregular, non-consolidated sleep pattern. Okay. So in terms of what we should do, well, we're going to begin ERRT. We're also going to delay your bedtime. You're getting in bed way before you're falling asleep at 10:30. So let's try to go to 10:30. If you're not sleepy, let's see when you are. Let's hold a consistent wake time. It's anywhere from 6 a.m. to about 11 a.m. Let's tighten that up. She said 7 o'clock seemed good to her. Okay. And let's get out of bed if we can't sleep. I'm just going to fast forward. We see from here, more consolidated. We start adding, delaying bedtime further, continuing all prior recommendations. Now we get something that looks a little prettier. And we tapered the ketamine, we worked on the THC, avoided daytime napping, and a lot of stuff with depression, okay? So something that you love to see, no nightmares, 2 exclamation points, much more consolidated sleep, going down to 0 nightmares per week over 6 weeks. Intensity started 8 out of 10, down to 0 out of 10. In terms of insomnia, that was severe clinical with the insomnia severity index down to a clinical absence of insomnia, and then depression from moderate down to minimal. And so this is just one case example. You have another one here. This was really life-changing for her. She'd been struggling with this for 16 years, and in 6 weeks, it was just amazing for her. It was great to do it, but it really speaks to the power of when you combine these treatments. And I see that we're at time. Here's another case example, and I'll just end here. If you want to get in touch with me, here's the email, here's the phone number. Do not be shy about that. And I'll just end. I know we're at time. I don't have anything after this. I'm happy to answer questions or reach out to me. But yeah, thanks so much for coming. It was truly a pleasure. And I wish we had more time at the end. Sorry.
Brian, I have a question, if it's okay. So I have a client who has a really similar clinical presentation to Megan, but she has a waterfall schedule at work. So basically, the beginning of her work week, she closes. And by the end of her work week, her 5-day work week, she opens. So, the end of her work or beginning of the work week, she gets off at 10 p.m. The beginning of her work week, she has to be there at 4 a.m. So she can't have a consistent sleep and wake time. And so I've really been struggling with how to help her with her sleep. I don't know if you have any suggestions for just the reality of that besides getting a new job.
So, but by the way, that right there talks to it's the mismatch. And especially when we talk about a swing shift or we talk about irregular shifts, getting a new job is one thing, but until that maybe happens or it can't happen, introducing as much regularity as you can and as much predictability as you can. if there's 2 days where this switches, well, how do you actually prepare ahead of time to maybe work on advancing your wake time or working with when you get in bed? Or is it just we accept the fact that, yeah, those 2 days we're going to get less total sleep time, but there's not so much uncertainty and unpredictability because you're building up adenosine, that sleepiness that you have. And as you start tracking it with the sleep log, which I hope that would be a first thing you do, that pattern, you can really start picking out, well, how is the sleep on the days when you can get your ideal schedule? And then how do we maybe make these little adjustments to better adapt and cope with these shifts that are going to happen on these other days? So without knowing detailed information, it's hard to kind of say exactly, but that's how I would approach it, is start tracking it and make it as regular as you can, knowing that that's just a constraint that this client has.
Okay, yeah, that is really helpful. Thank you.
Cool, you're welcome. Anybody else? Bring it on. Sleep.
Hi, Brian, it's Corey Lynn. I sent you a private chat because I wasn't sure if I could get you before you jumped off, but I was really curious about the ERRT protocol. How many weeks typically does that take?
Yeah, so if you do it from start to finish, like a 2-hour group, that's a 5-session group thing. For me, if you break that down individually, it's like 8 or 9 hours, 8 or 9 sessions. Typically, for me, the way I do insomnia treatment too, is I like to do a very thorough, this is a long-winded answer to say it depends. I would say 6 to 8 is kind of typical. I tend to be more around the 6 or 7 session because I tend to really try to target the specifics of what's interfering with sleep, including the kind of mood stuff and all that. But 6 to 8, 7 to 9-ish on average. Very rarely would you be going 10 sessions if you do it individually. Yeah.
And then just an additional question around that is, do you provide the ERRT training for clinicians? Like, where can we find out more information on training so that we can integrate that into our practices?
Yeah, it's a great question. So I'm actually, there's a group of clinicians who, there's kind of like this little network of ERRT trained clinicians, and I'm going to be a member of that network soon. So for me personally, I will be offering these trainings. I know in September, I have a day-long training on integrating CBTI and the nightmare treatment in DBT, specifically dialectical behavior therapy.
Yeah.
But then I'm doing 1 3-hour training just on CBTI, and then 1 3-hour training just on doing trauma-related nightmares. So that's a training that'll be coming up. I also can offer, I see here, provide training. I can do that for teams or individually. That would be more on a, work that out type of basis. But in terms of formal trainings, I can actually get in touch with the group and see if there's any other, trainings going on like nationally. But this is part of my career goal, is we need more people to do this work. And so, yeah, that's something I'll be offering down the road.
Okay. Great. Thank you. I'll be in touch.
Cool. Yeah, that'd be great. Anybody else? It doesn't, I don't want to take as much time too. I know, Laura, this is your evening as well. So I'm happy just to say goodbye or do whatever is clever, but anybody feel free to reach out whenever if you'd like to.
Yeah, I'm happy to stay on for a couple more minutes if there are additional questions. Maybe about 5 more minutes if anyone has more questions. And I just want to confirm, Brian, so you'll send me the ERRT like worksheet, and I guess maybe could you go over what you'll be sending me so I can send it out to others?
So I will be sending all of these slides. I'm going to be sending the sleep focused intake template that I use. So all the questions you can ask, it's more information than you'll probably need. I'm going to be sending the PDF of the sleep log, the one that I mentioned there, and I'll be sending the Excel sheet of the sleep log that you can transfer over. And it also has tabs for graphing various kind of measures that you can do. Unfortunately, I can't send like the treatment workbook for ERRT. That would be something that's proprietary, but those are the other materials that I'll be sending.
Great.
Yeah.
Well, if no one has any additional questions, we just want to say thank you so much. This was so informative and very interesting, and I'm excited to, I'm in school right now. I'm in the MSW program, but once, you know, I'm a clinician, I'm very excited to utilize this information. So thank you so
Nice.
much.
You're welcome, Laura. And thank you, everybody. And again, I'll just go back here. Do not be shy to reach out to me. My email, phone number. Yeah, I really want as many people to do this work as possible. So I'm always a resource for you if needed. So yeah, don't be shy.
Sounds good. Yeah, and I'll send everyone those resources probably later today or by tomorrow. So
yeah, that sounds great.
Yeah, thanks everyone for joining. And yeah, I'll send out this stuff soon. And otherwise, well, I'm not sure who our next presenter will be in May, but just keep an eye out for that information. So I hope everyone has a good evening and hope to see you all again soon.
Okay, thanks so much.
Bye.